Hello everyone. Am I audible? Can we start? So hello everyone, happy Lodi to all of you. So I hope you all have a wonderful exam. So I'll be discussing recalls from ophthalmology. Hello everyone. So I'm just starting with the questions. So can I get a thumbs up from all of you to start? So I'm starting with the questions, right? So question number 1, it was, what is the recommended maximum time frame for cornea harvesting after death to ensure optimal transplant quality, right? So options were 6 hours, 24 hours, 12 hours and 48 hours. So the correct answer in this was 6 hours, right? So correct answer was A. So in this, nothing to remember, it's just a fact that the cornea should be harvested within 6 hours of the death of a patient, right? So nothing to remember in this, it's just a fact. And after harvesting the cornea, we have to store it in the storage medium. So we can use either cortisol or MK media. So cortisol, we can store the cornea for 14 days. And in MK media, we can store the cornea for 4 days, right? I hope I am clear till this. Right, so next question. So it was, which of the following clinical findings can be assessed using cover-uncover test? Right, so the options were amblyopia only, latent strabismus, squint, nystagmus only, or both amblyopia and nystagmus. Right, so this I have very well explained in my videos on examination of squint. Right, so cover-uncover test is used for latent strabismus, right? So cover test, it is used for manifest strabismus, and uncover test, it is used for latent strabismus, right? So in this, what we are doing, so in manifest strabismus, we are just covering one eye and we are checking the movement of the uncovered eye, right? And in uncover test, we are covering one eye, right? And then after uncovering that eye, we have to check that eye's movement, right? I hope I am clear till this point. Just I am explaining it again. So this, so for cover test, I will be covering the right eye, right? If I am covering the right eye, I will check the movement of the left eye, right? This is cover test. But in uncover test, what I will be doing, I will cover the right eye, right? And then if it is a latent strabismus, right eye will move in the direction of the strabismus under the cover, right? And when I will removing the cover, so when I will be removing the cover, I will be again checking the movement of the right eye, right? So in this, in uncover test, I am covering one eye and I am checking the movement of the same eye after uncovering, right? In cover test, I am covering one eye, but I am checking the movement of the other eye. So this is the difference between cover test and uncover test. Right? So uncover test is basically used to diagnose the latent strabismus. Right? I hope I am clear till this. Right? So the next question was, which of the following is the most common late complication of cataract surgery? Right? So options were endophthalmitis, posterior capsular opacification, retinal detachment and cystoid macular edema. Right? So they have asked us the most common complication. So the endophthalmitis, it is the early complication. Right? And these two are the late complications. But they have asked us the most common late complication. So the answer will be C. It is posterior capsular opacification. Right? Cystoid macular edema is also a late complication. In a case of cataract surgery, if there is cystoid macular edema, in that condition we will call it as a Irwin gas syndrome. Right? But it is not most common complication, but it is definitely the late complication after the cataract surgery. Right? Now the next question was, what is the typical magnification which is provided by the indirect ophthalmoscopy? Right? So indirect ophthalmoscopy, you all know that indirect ophthalmoscopy, it provides us the wider view of retina. Right? So wider the view, lesser will be the magnification. Right? So it provides us almost about 40 to 50 degree of the area of visualization of the retina. So the magnification will be little lesser. So the right answer is 5x to 7x. Right? So B is the correct option, 5x to 7x. But I will also like you to revise with me the magnification provided by the direct ophthalmoscopy. So direct ophthalmoscopy, area of visualization is somewhere around 10 degrees. 10 degrees. So area of visualization is less, but in this the magnification will be more, right? Magnification will be more, so it is around 15x. Understood? Now some more differences about indirect and direct ophthalmoscopy. So in direct ophthalmoscopy, there will be virtual and erect image. In indirect, it will be real and inverted. In direct, it is 15x. In indirect, it is 5x. In this, the view of retina is 10 degrees. It is somewhere around 40 to 50 degrees. Right? It has a 2D view, 3D view. Right? Basically used to see the macular region, central region, used to examine the periphery. It is done that how much distance should be there within the instrument and the patient. So this is done as much as close to the patient. And this is done from one arm distance. Right? So these are the basic differences between virtual and direct and indirect ophthalmoscopy, right? So this is very simple to remember. This is just a fact, right? This you have to remember. Now the next question was, a refractive difference of 2 diopters or more between 2 eyes is referred to as, right? So in this, the options were hypermetropia, anisometropia, astigmatism and myopia, right? So the correct answer is anisometropia. It is anisometropia. Right? So in this what is happening, so if the refractive power of one eye is, for example, -3 diopter and other eye is having -6 diopter, so there is difference of more than 2 diopters, then we will call the patient is having anisometropia, right? So this is also this is the definition of anisometropia that you have to remember, right? So the next question was, the patient presents with homonymous hemianopia and a macular sparing defect. What is the most likely cause of this visual defect? Right? This also I have taught you very well in my videos. Right? So I'll just be revising it for you guys. So in this, the correct answer was lesions in the occipital cortex, or it can be due to the posterior cerebral artery stroke. Right? So I'll be just revising with you the visual field effects which are caused, vertical field effects which are caused due to the neurological abnormalities, right? So this is my eye and this is the optic nerve, and then finally goes to the optic cortex. So this is the temporal fibers and the nasal fibers are crossing, that you all know very well. And then so this is the eye, this is the optic nerve, right? This is the optic chiasma, right? After crossing from the optic chiasma, they will form optic tract, and then they will go to the lateral geniculate body. This is the lateral geniculate body, and after coming from the lateral geniculate body, they will form the optic radiations. Right, so this is the occipital cortex. This is the occipital cortex. Right, so if there is defect of the optic nerve, there will be complete hemianopia. Right, this you all know. So if there is defect of optic chiasma, there will be bitemporal hemianopia. This also you know. If there is lesion of optic tract, then if there is a lesion of right optic tract, then there will be left homonymous hemianopia, right? Same for the optic radiations. But if there is involvement of parietal lobe, right, then where will be the defect? Come on, tell me, where will be the defect if the defect is in parietal lobe? So the parietal lobe is superior fibers are affected, so the defect will be inferior. Pi in the floor, and if so, this is the parietal lobe, and if there is temporal lobe involvement, where will be the defect? Defect will be superior, right? Now there are two more conditions in occipital cortex, right? If the fibers which are relying on the posterior most part of the occipital cortex. So posterior most part of the occipital cortex, it is supplied by the middle cerebral artery, and this part of the occipital cortex receive fibers from the macular area, right? And other fibers from the occipital cortex, they are supplied by the posterior cerebral artery, right? So if there is involvement of middle cerebral artery, or there is involvement of the tip of the occipital cortex, then there will be macular lesions, right? Then there will be macular lesion. But if there is involvement of PCA stroke, or there is involvement of occipital cortex, then there will be macular sparing vertical left homonymous hemianopia, like this. So my answer is PCA, which is caused by it may be due to the lesion in the occipital cortex, or it can be due to the PCA stroke, right? I hope I am clear till this. Right, so the right answer is C. The next question was, a patient presented with intermittent non-pulsatile proptosis. MRI reveals a mass within the orbit. Which of the following is the most likely associated clinical presentation? Right, so the options were orbital varices, optic nerve glioma, orbital hemangioma, and lacrimal gland tumor. Right, so how to rule out the options in this case? So orbital varices and hemangioma, they will have pulsatile proptosis. So these are ruled out. Now we are left with optic nerve glioma and lacrimal gland tumor. So the lacrimal gland, where is lacrimal gland situated? It is situated in the supratemporal quadrant of the orbit, right? So if there is involvement of the lacrimal gland, the proptosis will not be too much, right? Proptosis will not be too much because the involvement is there in the supratemporal quadrant, right? So my answer is optic nerve glioma. So optic nerve glioma means is involvement of the optic nerve, and obviously optic nerve, if there is involvement of the optic nerve, it will cause the proptosis, which will be non-pulsatile, right? So the correct answer is optic nerve glioma, right? I hope I am clear till this. Next question was, which of the following is a known side effect of latanoprost, a prostaglandin analog used for glaucoma treatment, right? So the question, so the options were, so as per feedback I had from the students, they told me that the options were conjunctival hyperemia, retinal detachment, uveitis, and optic nerve atrophy, right? So the confusion is between the conjunctival hyperemia and uveitis, right? So the latanoprost, the prostaglandin analog, it causes both the side effects, but the most common side effect which is caused by the latanoprost is conjunctival hyperemia. So A more than B is the preferred choice, right? Conjunctival hyperemia is more common as compared to uveitis, right? So in a patient of uveitis, if patient is having increased IOP, we avoid using prostaglandin analog, because prostaglandin analog, they worsen the uveitis. That's why we avoid using a prostaglandin analog in a patient of uveitis. And along with that, they also cause conjunctival hyperemia. But conjunctival hyperemia is more common associated side effect of latanoprost as compared to uveitis, right? So A more than B is the correct answer. Now, a teardrop sign seen on MRI is typically associated with fracture of which anatomical structure? This also I have demonstrated very well in my videos on oculoplasty on orbit, right? So the options were nasal bone, inferior orbital wall, maxillary sinus, and zygomatic arch. The correct answer is inferior orbital wall, right? So if there is fracture of inferior orbital wall, for example here, there is a fracture of inferior orbital wall. So the contents of the orbit will come down in the maxillary sinus, which will appear to us as teardrop sign on X-ray, right? So X-ray or CT scan. So the correct answer is inferior orbital wall. Now the most common wall to be fractured or to be involved in blunt trauma is inferior wall. But if I ask you which is the weakest wall of the orbit, then the answer is medial wall. But now you will ask me the question that if weakest wall is the medial wall, then how come inferior orbital wall is the most commonly fractured wall? Because the medial wall of the orbit, it is supported by the ethmoidal air cells, right? So it is cushioned by the ethmoidal air cells. That's why the next weakest wall is more prone to blunt trauma, right? It is protected by the or cushioned by the ethmoidal air cells. Right? Now, the next question was, a 35-year-old male presented with a complaint of blurred vision and photophobia in his right eye following a blunt trauma from a cricket ball. On examination, the pupil appears irregular with localized separation of the iris from its attachment at the ciliary body. What is the most likely diagnosis? Right, so the options were hyphema, iridodialysis, traumatic mydriasis, and corneal laceration. So this is very much evident from this diagram that it is iridodialysis. So iridodialysis, it is the separation of the iris from the ciliary body, right? So it is the separation of the iris from the ciliary body, and in this, if you can see, they have mentioned that there is irregular pupil. And if you can see in this diagram, pupil is D-shaped pupil. So D-shaped pupil is there, and there is detachment of the iris from the ciliary body, right? So hyphema, it is the collection of blood in the anterior chamber. Which is not here. You can definitely see it is not here. Traumatic mydriasis, it is the dilation of the pupil due to the damage to the sphincter fibers. Due to damage to sphincter fibers. Due to damage to iris sphincter, or due to damage to optic nerve. So mydriasis can be because of two reasons in a case of trauma: if there is a damage to optic nerve, or if there is damage to sphincter of the pupil, right? Corneal laceration can be there in blunt trauma, but in this diagram you can see the cornea is absolutely clear. So my answer is iridodialysis, option B, right? The next question was, a 65-year-old male underwent uneventful cataract surgery 3 weeks ago. He now complains of painless blurred vision in the operated eye. Fundus examination reveals cystic spaces in the macula. OCT confirms the presence of macular edema. What is the diagnosis? Right? The options were retinal detachment, Irwin gas syndrome, posterior capsular opacification, and endophthalmitis. Right? Now, how to rule out the options? Although you need to know the correct answer, but I am just telling you a trick how to rule out the options in this case. So posterior capsular opacification, you all know, will happen on the posterior part of the lens capsule, right? So it will happen on the capsule, it will not happen on the retina. So this option is ruled out because you can see there is a diagram of retina, right? So we are left with retinal detachment, Irwin gas syndrome, and endophthalmitis. So endophthalmitis also you all know that it is the early complication of cataract surgery. Right, now we are left with two options, retinal detachment and Irwin gas syndrome. Retinal detachment means, you all know the definition, it is the detachment of the neurosensory retina from the retinal pigment epithelium. NSR detached from RPE. This is the definition of retinal detachment, which you can see in this diagram, it is not there. So we are left with only one option, that is B, it is Irwin gas syndrome. Right, Irwin gas syndrome is also known as cystoid macular edema. Now, what are the risk factors by which in which cases you will expect that cystoid macular edema can occur? So, in which the surgery has lasted for a very long time, long surgeries, long duration of surgery, right? Number one, or there is a complication after cataract surgery, complication in, or there was a complication intra-op or during the post-op. Complication intra-op, there can be PCR or there can be vitreous loss, right? Or there is underlying secondary condition in the eye, which can be uveitis. So all these conditions, they predispose the patient to have cystoid macular edema post-operatively. So cystoid macular edema has many other causes, right? The most important is diabetes mellitus, but it has many other causes also. I'm not going into that. But you need to remember that if cystoid macular edema is occurring after the cataract surgery, it is known as Irwin gas syndrome, right? So what is the treatment for Irwin gas syndrome? We can give NSAIDs. But if we are not able to treat the patient by NSAIDs, then we can give steroids, or we can give anti-VEGF. So this is the treatment for cystoid macular edema or Irwin gas syndrome, right? Now the last question was, which of the following condition is commonly associated with Marcus-Gunjaw winking phenomena? So this question I was not able to get the correct options, but if the question was this, so I am assuming that answer should be ptosis. Now, why the Marcus-Gunjaw winking phenomena occurs? It occurs due to the miswiring. It occurs due to the miswiring. So, it mostly seen in congenital ptosis. So, whenever the patient moves its jaw like this, sideway movement of the jaw, like this. So in that condition there will be elevation of the lid. The ptotic lid will elevate when there is a movement of the jaw. Right? So there is miswiring between the third nerve and the fifth nerve, which is supplying the internal and external deltoid muscle. So this is the cause of Marcus gun jaw winking phenomena, which is most commonly seen in congenital ptosis. Right? I hope all of you had a wonderful exam. Right? So this was all the recall session that I could collect. Right? So I hope that all of you had a wonderful exam, and I wish you all the very best for the results. Right? Thank you very much.